Hello, everyone. This is Bella Mehta from New York, reporting for Room Now. And I wanted to talk about managing lupus pregnancy and navigating this almost minefield. It's a tough one whenever you have a patient like this. So I thought it would be nice to talk about it. I'm going to talk about a case. This is a 28-year-old woman who comes to me for the first time in order to discuss pregnancies. Um, so this is a known patient with lu- lupus nephritis, manifesting a few years ago, at least 6 years of disease, has had a rough course, ups and downs, has had a kidney biopsy which shows class 3 lupus nephritis, was treated with a whole bunch of things at that point, steroids, immunosuppressants, and finally, right now, she came to me in anticipation of pregnancy planning on three drugs, hydroxychloroquine, MMF, and prednisone. So, MMF or Cellcept is not something that you want patients to be on when they're pregnant. So, this at the first visit, when we talked and sort of discussed, she's been in remission. The kidney numbers, the protein in the urine have all been low to none. First thing to learn about in lupus pregnancies is that is this the right time? And the best time to plan a pregnancy is when you're in remission. So seems like like a good case for that. And then we discussed about medications. So some of the medications that we typically use in lupus or lupus nephritis may not um, cannot be continued through pregnancy. One of it that the patient had was Cellcept or MMF. So we switched the MMF to azathioprine in anticipation of pregnancy. Now, a few months later, the patient does get pregnant, comes back. At that point, we do testing, specifically SSA, SSB, as well as APS testing. And again, so these are specific labs that you want to know either preconception or early in pregnancy because of different risks or different things that you got to monitor during pregnancy. So both SSA and SSB increase the risk of neonatal lupus or congenital heart block in patients, in babies. So in this case, actually, we knew that the patient has SSA and SSB positive. So we knew that this is a patient which will require much more monitoring. And we ordered antiphospholipid panels. For these patients, for this patient, which did turn out to be negative. Of note, this patient did not have a history of a lot of miscarriages um, or early pregnancy losses, which again put APS at a higher risk. And these are the patients that you need to monitor, maybe even start aspirin if they've had multiple early pregnancy losses. But for this patient, APS was negative, did not have early pregnancy losses. So now, since the patient was pregnant, she was on hydroxychloroquine and azathioprine. Prednisone was tapered almost off. It was like 1 or 2 milligram. At that point, I don't think it was doing much. She thought it would probably help with her joint pain, but eventually we tapered it off through her first trimester itself. Things that we monitored throughout her pregnancy were the usual CBC, CMP, which includes creatinine, liver function tests, disease activity monitoring throughout pregnancy is very important, uh, especially double-stranded DNA and complements. And again, complements in pregnancy are a little tricky, but it's good to have a baseline before patients get pregnant, and then you can monitor it through. Um, since this patient had Rho and La positive, both, fetal echocardiograms are recommended. Usually around 16 weeks to 26 weeks to screen for congenital heart blocks. And of course, these are high risk pregnancies, especially patients who've known no lupus nephritis in the past, and all of these antibodies. The patient did not have uh, other medical problems, but a lot of these lupus uh, patients who are pregnant can have comorbidities. So that's also something to watch for. And, for managing these patients, a multidisciplinary team is very, very important. Um, Ultrasounds for monitoring fetal growth every 4 weeks, starting the second trimester, is also something that is recommended. And most OBs who you'd work with for managing such cases would do that. And again, hydroxychloroquine was, of course, continued. Prednisone was eventually stopped. Azathioprine was continued. And one of the things, sort of late at around 28 weeks, she started having some symptoms. Um, one or two incidences of increased blood pressure. So that's when we were starting to worry about preeclampsia or eclampsia. And she did well, but around 35 weeks or so, her blood pressure really started to go up. And at that time, um, again, it was managed uh, with cardiology with us, but eventually the patient delivered at full term, um, and we had to do a C-section. But most patients, when we monitor these patients closely, do fine. I just wanted to bring up that when she had these little bumps in blood pressure, we were worried, is this a lupus flare or preeclampsia or eclampsia? And there are key differences, and it's very, very important to be able to differentiate eclampsia versus lupus nephritis, especially in pregnancy, like late pregnancies. Early pregnancy, usually that it's lupus nephritis mostly, but late pregnancies, the picture can be confusing. So some things to note: hypertension is much more common in eclampsia or preeclampsia than lupus nephritis, which sort of gradually goes up, or it may not be present in some cases. And again, preeclampsia and eclampsia usually occur after 20 weeks. And again, both preeclampsia, eclampsia, and lupus nephritis will have protein, and that's when things can get confusing. But in eclampsia, preeclampsia, the protein can be severe, and it may not have a trend like in lupus nephritis, where you see gradually the protein levels going up. It will be like suddenly the patient's protein levels in the urine have started increasing. One thing that if you can take away, how do you differentiate eclampsia and lupus nephritis, is active sediment. So in nephritis, you'll see active sediment as in casts, RBCs, hematuria, cellular class, which you usually don't see in eclampsia or preeclampsia. And again, all the usual lupus serological factors, low complements, anti-dsDNA, which is high, all of those things is what you'd see. And usually if you have a lupus flare, everything flares up, like joints, all of that. So there's some hints, but sometimes in late pregnancies, patients have joint pain and aches, and it's sometimes difficult to differentiate. So I know it's not done all the time by nephrologists inpatient, but if you're suspecting lupus nephritis versus preeclampsia, you could request active urine, sort of a spinning of the urine, see the sediment, look for casts, and that would be a key differentiator. So I think all in all, lupus nephritis um, um, is a tough thing to navigate, especially during pregnancy, because you can't give all the drugs that are out there. Obviously, cyclophosphamide is tough. Giving high dose prednisone might be difficult. Sometimes, given the blood pressure can be high. So overall, I think sort of three things that I would want you to remember for these: counseling patients to try and plan pregnancies, which would be ideal. Once pregnant, make sure that you do appropriate testing and monitoring. Rho, La, and APS testing. And if you have any of these positive, do echoes or fetal monitoring appropriately. And lastly, how to differentiate preeclampsia and eclampsia with active lupus nephritis, and most of it, sort of the money lies in the urinary sediment, as well as obviously the usual markers of lupus, which is complements, double-stranded DNA. With that, I think I wanted to emphasize that in this complex scenario, it's great to have a multidisciplinary team monitoring and managing these patients with rheumatologists, nephrologists, OBs, and depending on what the patient's manifestations are. I hope this case helps you manage these patients better. And for more of these, please follow me on Twitter at Bella_Mehta and follow for more content on Room Now. Thank you.